Good afternoon. I'd like to start by introducing myself. My name is Gina. I'm the current president for the League of Women Voters of the Mount Baldy area. The League is a grassroots organization that provides members with opportunities to learn and educate others about government and take action on public policy. We have a few events coming up soon. First, we will continue our Discussing Democracy series with an in-person gathering on Thursday, February 27th at 7 p.m. at Garner House in Claremont to discuss youth voting with some really incredible young people. Additionally, the National League is working on a study of the federal judiciary. As an introduction to the study, the League held a town hall with some experts. That recording is on our website, and you can look for announcements about how you can participate in that process through our local league in March. But I'd like to begin today's program where we'll discuss the local impact of Prop 1, which passed in November of 2024. I'd like to introduce our two presenters. Thank you so much for being here. First, Sarah Rodriguez is a licensed marriage and family therapist and has worked in the mental behavioral health field for over 20 years. The past 10 years, she's worked for Tri-City, serving the communities of Pomona, Claremont, and Laverne, currently acting as Tri-City's MHSA projects manager. Mary Monzon joined Tri-City Mental Health in 2017, bringing over a decade of experience working with youth and families through nonprofit organizations. As housing manager, she leads the planning, development, and management of Tri-City's housing division. After I turn it over to Sarah and Mary to begin their presentation, we will have a few minutes at the end for some questions and answers. So please, as they come to you, feel free to enter them into the Q&A. And Sarah and Mary, you can start. Thank you so much.
Thank you very much for that introduction. Let me go ahead and share screen. Someone just let me know if there's some kind of issue with visibility, but this should work perfectly. All right. So again, here today, just really to go over the implications of what Proposition 1 means for our communities, means for community mental health in particular. And since we are coming from Tri-City Mental Health, this is really speaking to community mental health in Claremont, Pomona, and Laverne. So we're going to speak in terms of what is right now, but what will shift to BHSA. So currently, Mental Health Services Act, or MHSA, will turn to Behavioral Health Services Act, or BHSA. So we're going to get into an overview of MHSA, a little bit of background of where this all started, a high-level introduction to BHSA, because the reality is there's still a lot we don't know as we are in transition, and a lot of draft modules still need to turn into approved modules, official modules. We're going to talk about the projected fiscal impact that will occur with Tri-City and, again, all the counties throughout California. Our next steps, we're going to focus on Tri-City's housing division, and that's where Mary Monzon, my colleague, will take over, and then, of course, have a segment for questions and comments. So a little bit of background on the Mental Health Services Act. So this was very much a huge change, one of the biggest changes that we had seen in community mental health since the mass closure of state hospitals in the late 60s that continued for many years. In 2004, California voters passed the Mental Health Services Act, and again, in part, it was response to some gaps that happened in services, to say the least, right? When the state hospitals closed, we saw homeless rates go up. We saw more individuals experiencing needs related to mental illness or related to substance abuse, and really that network wasn't there to support them. This is funded through the millionaire's tax. So in California, individuals that make a personal income over $1 million, 1% of anything that exceeds $1 million is taxed. It goes to the state first. They take 5% off the top, and then the rest of the money trickles down to all the counties. And that's how MHSA is funded currently. And what's interesting is when MHSA first started, this accounted for about 10% of funding for all of community mental health. And now it's risen to about 25%. So it was very successful, and also reflects the amount of millionaires we have in California, because we saw that go up and up and up over time, which also makes it a little bit volatile because that number can go down. It's definitely not a static number every year. So currently, there are 5 components to MHSA. We have our community services and supports, prevention and early intervention, innovations, capital facilities and technological needs, and workforce education and training. These 5 components are the same in every county across the state, but the specific programming you might see in each component is going to look a little bit different because each county is trying to meet their own community's needs, but these components are always the same. Now, again, Proposition 1 passed last year in 2024. So after 20 years of MHSA, we are going to be pivoting to the Behavioral Health Services Act. This really intends to expand on the foundation that the Mental Health Services Act created. And the key word that indicates that this is the goal is just the word mental health changing to behavioral health. You can encompass a lot more when you're addressing behaviors as well. And because everything is so new, because so much information from the state is getting trickled out, a lot is still in draft mode, and the counties have county to county work groups about addressing what the state's expectations are and what counties can feasibly do. We are going to have state meetings in the future, additional work groups. We're going to continue presentations like this as new information becomes solidified and available. So Proposition 1 has 2 major components. The Behavioral Health Infrastructure Bond authorizes $6.38 billion to build or develop behavioral health housing and treatment facilities. And then we have the Behavioral Health Services Act, or Senate Bill 326. This really aims to improve and expand behavioral health services and housing interventions for individuals with severe mental illness, emotional disturbance, and substance use disorders. And just a friendly reminder again, this was passed last year. And for the sake of today's presentation, we really want to focus on that BHSS component, behavioral health services and supports. So BHSA funding does change the way we are able to allocate dollars spent. First, we are going to see that the state is taking a bit of a larger chunk off the top. So with MHSA, they took 5%. Now they're going to take 10%. And the breakdown of this really goes as follows. 3% is going to the Department of Healthcare Services. 3% is going to workforce education and training, which is, if you remember, workforce education and training was one of the 5 components, right? Now it's 3% off the admin. 10%. So we did see that shrink. And then 4% for prevention. And this is through the California Department of Public Health. What this does also, it allows us to fund things that we couldn't necessarily fund before. So this is going to be used for drug and alcohol treatment for people without mental illness. Under MHSA, mental health, you really had to look at individuals and support individuals that had a diagnosis in the DSM, the Diagnostic and Statistical Manual for Mental Disorders. So someone who might have struggled otherwise, maybe have a substance use concern, or might be experiencing homelessness that did not have a mental health diagnosis, fell between the cracks. So again, trying to work to expand on what was created by MHSA and really do something more under BHSA. And this also prioritizes housing and the chronically homeless. So the 5 components I mentioned before, this is the breakdown we operate under right now. This is what we are going to operate under until July 1st, 2026 of next year, when everything goes into effect officially. So community services and supports is 76% of MHSA monies that comes down from the state. Half of that goes to our full service partnership, or our programming that supports individuals that have the highest level of needs. They may be experiencing more severe symptoms as opposed to moderate symptoms. And with that come the impairments that occur as a result of those symptoms. And so that's what we talk about when we say FSP, or full service partnership. And since most of the monies goes to community services and supports, this is also where you're going to see at the bottom of this breakdown, capital facilities and technological needs and workforce education and training being funded by unallocated dollars from CSS, simply because it's the biggest chunk. So if we have money to roll over, it comes from CSS typically. The next largest bucket is prevention and early intervention. This is going to be half of this is going to the children and the transition aged youth, so 0 to 25. And then finally, we have innovations, where 5% of funds go to innovations. And that's really trying, soliciting the community for letting us know, what can we try that's different? What can we try that's new? What can we do that again is very innovative and something we've never tried before? Under the new breakdowns, we have three major buckets. I did pull out just the 10% below as a reminder that the state is taking double what it did before under MHSA. And here we have full service partnership, which is going to be at 35% of BHSA funds. We have behavioral health services and supports, which is going to be 35% of those funds, and housing, which is 30%. So, as part of what we're involved with right now and will continue to be involved with is these ad hoc groups through our liaison. Each county is working with the California Behavioral Health Directors Association, or CBHDA, and they really act as liaisons between the state and the counties. And all of our messaging and communication goes through CBHDA. So what you see here is just a really simple chart with the 8 committees that we have. I'm attending something, for example, I'm attending the prevention and early intervention group. And at times I also attend the community defined practices and evidence based practices group. Each county is only allowed 2 to 3 individuals per county to attend. And really, this is just, again, an opportunity like stakeholders would come in, say what they think is going to benefit their county. If the state has put something out that we find unrealistic, we flag it, we lift it up, and hope that we come to, at some point, something that we are able to do that we can adhere to the state's expectations and deliver to our communities, and do it in a realistic way, in a sustainable way. So next steps for us, friendly reminder, Prop 1 doesn't go into effect until July 1st, 2026. So we're going to continue with our current programming and funding streams until then. However, if any decisions are made regarding program updates or program changes to current MHSA plans, or creating new programs, we do have to view those potential changes through the lens of BHSA while still MHSA. And really, again, that's just in light of sustainability, right? We want to make sure that things can roll over and change under the new umbrella of BHSA. So we're going to continue to review the guidelines and requirements set under Prop 1 as we consider any program changes that might be updated. And because BHSA is technically tax dollars, this is always going to involve the community. We hold several stakeholder meetings, we take votes, we run a community planning process, survey to get input from community members regarding changes we make. And everything goes through the standard stakeholder process to make sure that this is well informed by the community. And really, the goal is to preserve all or as many MHSA programs as possible. As you saw the bucket shifts, there were some significant changes that are going to happen. So we are working every day. Our executives are working every day. The community is giving input into how we can continue what we're doing and make it better. And that being said, I do want to, one last note, I apologize. The typical stakeholder process for us, and many of you may be familiar with this, but we go through the community first. Then we present our information to our commission, who acts as an advisory board to our governing board, who then, if they approve something, it goes to the stakeholders for feedback, and then ultimately would go to the state. So that is kind of our process with any plan, with any change. And with that, I would love to hand it over to my colleague, Mary, and we will definitely have some time for Q&A at the end.
Hi, good afternoon, everyone. Happy Sunday. Thank you for joining us and allowing us to be here to share more about this. I'm here to let you guys know a little bit more about our housing division within Tri-City and why we see where the benefit of the changes with Prop 1 are going to fall, because there is a need related to housing within the 3 cities, really within the county and the state and the country. But we see the smaller picture here, and we identify how Prop 1 is going to be able to help us. But here at Tri-City, we follow housing as mental well-being. We understand that individuals with mental illness are going to be more successful with housing, and that is a part of their mental, like it's all works together, right? They'll be more successful with their housing, but also they'll be able to work on their mental health once they are housed. So it all works together. Go to the next slide.
Sorry, I'm trying. Hold on.
No worries. I see. We do follow the Housing First model, which identifies that housing is a human right, that the individuals who are being housed, they have a choice and control over the users that they work with. There is a separation of housing and treatment, that we're focused on recovery and harm reduction. There is active engagement without coercion, right? There's no this for that. It is very person-centered. Everybody is different, and what their personal goals and what their treatment process is going to be different from the others. So it's not just a cookie cutter approach for every single individual person. And then we're flexible for as long as they require it. Some people really just need it to get into the housing to really to start getting all their ducks in a row. Some people still need a little bit of time. We've had individuals who, after being homeless for years, and they've not had contact with family, once they move in, they identify that they physically need a year to get settled, to set up their home before they can go ahead and even just start reaching out to family and let them know that they're housed, right? As some people immediately want to tell their family that, look where I'm at, come check me out. So it really just, everybody is different as far as where their recovery comes in after they get housed and while they're going through the process. Next slide. Just a little bit about our team. We're a small team within the agency because we've really just been a part of the clinical services within Tri-City. So we have 2 outreach specialists, one that helps field referrals from within our agency and oversee certain vouchers or certificates to help people maintain their housing. We have one who is an outreach specialist for landlords. We understand that it's not just important to help the people who are being housed understand their rights and responsibilities, but we want to make sure that we're getting connected with landlords and understanding what their needs are, what they're seeing in the properties where they're renting out, and that they're aware of resources that are available in the community. Because if they recognize that they've had a tenant for years who's never missed their rent, they've always been on time, and all of a sudden they're late, they're starting to be short, maybe there's something there and they can connect them to resources in the community, food banks, or a church that might be able to support them during a hard time, instead of going straight to, let's send a notice of eviction or lease notices, what may be. So we want to make sure that it's a collaborative effort between, again, the community who is trying to get housed, but those who have the keys to house people. We have one housing navigator for our agency, which with Prop 1, that we'll see more of that. And then we have 3 RSCs, residential services coordinators, which I'll go into a little bit more about what they do, but we really have been able to get more involved in permanent supportive housing within the 3 cities over the last few years. And then we have Cynthia Vega, who's a housing supervisor within our department, and then myself. So as I mentioned before, we have our 3 residential services coordinators who work on site at 4 different properties within the 3 cities. We've been lucky to partner with developers who are looking to build more low-income, affordable housing within the 3 cities. And in these units, we've been able to partner with them, provide some funding so that we can oversee a set of units where we're providing the direct supportive services, checking in with them on a regular basis. As they move in, we start from the beginning when they're completing their applications. Once they move in, helping them get settled, understand their lease. And as they're there, this can be very overwhelming for individuals, especially if you've been homeless for a number of years, or if this is the first time that you're the person who is on a lease. It's a lot of responsibility. And so to have somebody there who can guide you and help you understand what it all means, help you keep on track of, like, how do you budget your bills? Because now you have, on top of your rent, you have your utilities while you're still taking care of your other daily needs. Making sure that there's somebody there who can, when there's a notice about them having to come in to do an inspection, not to panic and understand this is just a regular occurrence. And maybe they can go in and check their unit and help them look to see if there's anything that they might be able to spiffy up before the inspection occurs, right? So we're there to support them on those ends. And that's what we are there for, the support. We do not take over any of the property management. We do not own the units. That is not our role. The property manager still functions as normal. They still have the say over what happens. We are just there to support the individual and also inquire if there are alternatives. If somebody is having, we've encountered where individuals have noise complaints from their neighbors because they play their TV or their radio late at night. And then once you start talking to the individual, you realize that they have their hearing is starting to go down. And so we help connect them to get, their medical care. And now that was something, a problem that was averted, right? Because we looked into it and tried to help bridge the communication with the property manager and the tenants. So those are the 4 different properties that we are lucky to be able to be a part of here in the 3 cities. And then on top of that, a big piece of what we're here to do is help support, again, the clinical team. Whenever somebody identifies that they have a housing need, whether it is they're unhoused and they're looking for somewhere to live, they're currently housed, but their rent is getting higher and they're really fearful that they might not be able to maintain it, so they're looking for something more affordable or looking to expand because they have more family moving in or a new baby. Individuals who are housed and maybe have concerns with their unit because there's mold or something that's not getting taken care of, or they've received a lease notification that they don't know what it means. Again, our RSCs on those sites are able to help that. So we're able to do this here in the community. Or if somebody receives an eviction notice, we are not here to stop evictions. We don't have any of that power. We don't have any legal jurisdiction over this, but we are here to help the community also understand what it means when you do get an eviction notice in those circumstances. Oftentimes people panic and they feel that they have to leave immediately because they don't want to have this record following them. And we help them understand, look, it's a process. It'll take a couple weeks. This is what you can do. This is how you can support yourself. Here's the legal resources that you can get connected to. So we're able to support the referrals that come in directly from Tri-City clients. But one of the things that we look at is we take data from the referrals that come in. And so just since July of 2024, so at the beginning of our fiscal year, we have received 334 in-house referrals, and we only receive in-house referrals at this moment. 204 of those referrals were people who were unhoused and looking for housing. So in the questions that we ask during the referrals is just for reported incomes. And if we're looking at the wheel here, the dark gray area that says 26 and 8%, that's the number of individuals that did not report income because sometimes they just don't want to share, and that's okay. And then we have 37 individuals who absolutely had no income. 104 who were who had GR, general relief, which is just a federal or governmental assistance of $221 a month. Then individuals who were above that but below $1,000, we had 42 people. 76 individuals fell between 1,000 and 2,000. 26 people between 2,000 and 3,000, and only 22 people, so 6%, had over 3,000. So I make a note here that only 22 of the 334 referrals might have enough income to be able to qualify for their own apartment at market rents. And that's what people are asking for, right? They don't want shared housing. They don't want anything else where it's congregate setting. They want to be able to have their own individual spaces for various reasons. Nobody ever wants to have to share. But this is the only individuals within these referrals that we are potentially able to help with this. And I'll show you how we get to the might. And so every year HUD identifies what the fair market rents are. They used to do this for the county. It was all one number for all of LA County. And at the beginning of this year, they changed it up. So it is by zip code. And so we have the fair market rent, which is this is what rents are really going for within the 3 cities, where efficiency, that means studio, your bedroom is your living room, sometimes your kitchen. So studios in Pomona should be going for about $1,600. In Claremont, 2,111, and in the Laverne for 2,040. And you see each of the different ones go up, right? One bedroom is 1,800 in Pomona. If we can go to the next slide, Sarah. within Tri-City, one of the things that we like to do to help the community, not just our clients, is we look for the most affordable housing within the 3 cities every 2 weeks. So every 2 weeks, we put out a listing that's available at the front desk of any one of our buildings, and we're looking for the cheapest housing. And we create a little listing and we share it out with the community so they can look, right? That they have an easy access to be able to find the cheaper housing within the cities. I was able to pull the data again from the beginning of our fiscal year of July 2024 of those listings that we were able to identify in the 3 cities and compile numbers as far as the average, the lowest, the highest rent since July 24. But I will note this truly is just on the lower end of rentals in the 3 cities. There's far more rentals that are occurring on the higher end, on the mid to higher end. We're not tracking those because that's not really what we're sharing with our community members. And so the data that I have here is solely for those lower end units that we're looking at. And even there, when we look in Laverne, the average rent for a studio is $17.98, which it does fall below the market rent, which it should. If we're looking at the lower end, it should fall below market rent. And then in Claremont, the studio is $16.25 and Pomona is $16.47. Oh, sorry, $14.87. All right, the 1 bedrooms, you can see them going up. And on the bottom, I have the average required income. I will go into that in the next slide, but I just wanted to see what the rents are looking like and how quickly they rise as you go up with the bedrooms, and just how difficult that can be on one's income. But if we go to the next slide, so in all the listings, whenever somebody puts out that they have a unit available, they identify it's a 1 bedroom, it has a shared bathroom, or it has a yard, no pets, give you all the details. And one of the biggest things that we look at is what the required income is for their rentals, because the landlords can set this. They are able to identify what the required income is for their units. And so within the same rentals that we looked at from July 2024 to now, I was able to look at the incomes that they were requesting. The lowest was 2 times income. Nobody obviously wanted 1-time income. They wanted at least 2-time. Most of them were 2.5 to 3 times the income required in order to rent the units. So when we look at that, the required income in the city of Pomona just for a studio is $37.16, in Claremont $4,062, and in Laverne $44.93. So a lot of the individuals, as you saw in the income and the wheel that we had earlier, they don't fall anywhere near here, right? We had 22 people who had over 3,000, but it's not, those people, from what I remember, they weren't at the higher end of 3,000. They were really low end of 3,000. So they might still struggle to even get that studio in Pomona. They might not have the income. And then the individuals that we work with at Tri-City, a lot of them they're either older and are retired and are on SSI, or they have a disability and they receive SSDI. And the monthly award for that is $1,206. And so again, when you're looking at that for incomes, they're definitely not able to afford that. And then when we start looking into the community minimum wage, right? This year it's at $16.50. For healthcare and fast food workers, it's up to $20 an hour. Even if somebody is able to work full-time, what we're looking at is $26.40 per month or $3,200 for the healthcare and fast food workers. That is still not enough for the studio. These individuals need a secondary income, either another person or they have to work a second full-time job in order to try to get there. So it's really hard when we're trying to help our individuals in the community just get housed so they can sit down and focus on their mental health, on their physical health, on their family. It is really hard to find housing that's affordable within the 3 cities. And so just one of the things that this is a big change. Prop 1 and everything that's going through is a big change, and we're still, every day it changes. Every time there's new guidance, we're not really sure where we land on this. And so one of the things that within our agency, we were very focused on identifying is that we recognize this is difficult to not know what's coming and to accept how things are going to be a little bit different. But any little change that happens always feels difficult. If you just rearrange your where you set all of your things on your desk, the next time you come in, you're going to be a little bit thrown off by where you placed items. So we just know that, Sarah, if we can go to the next slide. Any change, even a change for the better, is always accompanied by drawbacks and discomforts. So within our agency, we ask staff to just work with us and to be part of the process. Like Sarah identified, we're very big on making sure that there is a lot of communication between the staff, stakeholders, our government governing board, and then going back to the stakeholders. It's an ongoing conversation, but also with the state and the counties. There's a lot of conversation. It is not just this is a change and now here are the guidelines that everybody has to go with. There's a lot of back and forth to try to figure out how we can make this work. So it's a lot of change, but we're here for the challenge because we do know that there's going to be a lot of benefit to the community for this. So with that, we are more than happy to take any questions that come up here.
All right, thank you so much. None have popped up yet, but I wrote down a couple if that's okay.
Yeah.
Right now in Claremont, there's been a big push amongst some tenants groups to have a rental registry. I'm curious if that is something that would be useful for you guys as an organization. So, because as of right now, are you collecting all of that data yourselves?
Correct. So it's just one of our housing outreach specialists, one that works with landlords. She just goes around pulling either things that are online or we're out boots on the ground looking for signs and windows and on lawns. So yes, a registry would be very helpful. And it's not just for us, it's for the community, right? Because this would be able to show the tally, even the middle and the higher end rentals. Like we just need to know what's out there so that everybody can find housing within their range.
Right, absolutely. Thank you for that.
Mm-hmm.
And for folks who are not familiar with Tri-City in general, housing is a huge issue for us as a league, and it's so incredibly important. But could you guys give just like a brief overview of what Tri-City does in addition to that?
Yeah, Mary, if you want me to take that one on, and definitely please help me if I miss something. So many years ago, every county was given the opportunity to, again, run their own community mental health programming. Now there's 58 counties in California, including Los Angeles and Alameda County. Berkeley pulled out of Alameda County and decided we wanted our own funding. This was an open period of time in the state where this was allowed, and communities were able to separate from the larger county at risk of feeling like they were going to get underrepresented. So, for example, us, Tri-City, we're Claremont, Laverne, and Pomona. We act as the mental health authority and are our own county when it comes to community mental health funding. We still have to report to the LA County plan, and we still work together and are very much cohesive, but we get our own funding. So 58 counties, 2 authorities, Berkeley and the Tri-City area. And yes, we have your traditional therapeutic clinical services, anything from adult outpatient, which individuals, in very broad terms, you could say these are individuals experiencing maybe moderate levels of mental health symptoms and impairments, and then all the way up to your full service partnership, which is going to be, again, those more severe impairments, severe symptoms that people are experiencing with a diagnosis from the DSM. Something we also, as a community mental health authority, we're mostly working with individuals that have Medi-Cal. So a lot of times we'll get calls from individuals that might have Kaiser or some other private insurance. And we don't just say sorry. We have our teams that make sure that bridges are built, that we do warm handoffs, that we do get people connected to where they need to be. I could do a whole hour presentation on the other stuff that we do, but in a nutshell, the prevention and early intervention components, anything from our therapeutic community garden that utilizes therapeutic horticulture for both clients and non-clients. You don't have to have Medi-Cal. You don't have to live in the 3 cities to go to our wellness center, which has movie nights, free cooking classes for the community, tons of events and support groups at the wellness center. And of course, the campaigns we have, like our Green Ribbon Week campaign. We have Creative Minds, which is a bureau of individuals who just say, I've gone through the system before. I've had a diagnosis before. I've been to therapy as a child. I now want to speak to community members. I want to speak to individuals to let them know about my journey. Because another thing that's happening in mental health in general is the peer is being valued. The individual that might not have the doctorate or the master's degree, but they too went through the trauma that the individual who's looking for services experienced, and they align. And if the clinical implications are there, then they get a therapist or a case manager, psychiatrist, etc. But the value of the peer has just skyrocketed exponentially, and it's a really beautiful thing. So yes, there's a lot of services we have that aren't necessarily saying you need to have Medi-Cal and you need to be an enrolled client for clinical services. There's a lot of open services for community members. And if you have a question about a specific program, or if you're interested in hearing about how to get free mental health trainings, like one of my favorites is mental health first aid. And it looks at our thoughts and our feelings and the mind and the brain through like a CPR lens. Oh, this might be a sign that I'm about to have an anxiety attack. My friend over here is depressed. Here's ways I can support them. Not that you're clinical, but here's ways that I can align with and walk along my friend who's going through something really, really difficult. So mental health first aid is a fabulous free training for anyone in the community. But like I said, I'll stop there. I can go on and on forever about the other non-traditional clinical services that we have.
Yeah, I think we all really appreciate how tied in you are to so many facets of these communities. You know, working in public ed in Claremont, you come across the work that you guys are doing too. So I think we all really appreciate it. Sarah, we were talking off recording briefly about that transitional age for our foster youth, foster and adopted youth. And I was wondering, and you mentioned it in your presentation, if you could just briefly talk about how important it was to change from that 18 cutoff kind of idea.
Yeah, and really this is like half, speaking from Tri-City, and the other half just my personal feelings about it. But forever it's been 18, you're an adult, right? Legally at 18, you are viewed and treated and legally addressed in very different ways than a 17-year-old. But what's really neat in the world of psychology, in the mental health field, the transitional age youth age group was created. So that spans from 15 to 25, because the reality is, as we know that our brains are very malleable and the brain never stops developing, the heightened period of time for brain development, and kind of, I don't even want to call it a plateau, because again, the brain keeps developing, but the peak of development doesn't stop until about your mid 20s, late 20s. So it was really nice for psychology as a whole and mental health to say, no, we need a transitional age youth group that's distinctive from what we consider an adult legally. So they're really looking at more, where is the brain at? And an 18-year-old, I mean, again, to each their own, they are not an adult. They still have a lot of learning to do. There are still so many developmental stages that they're going through. So yeah, the transitional age youth group, I think, has just been a very valuable way to look at a young adult.
Yeah, thank you, Sarah. We have a question in the Q&A. Do you connect with all low-income developments like Courier Place in Claremont and the Apartments for the Disabled on Town Avenue?
Not directly, like we don't have like our housing division doesn't have a service there, just because it mattered as far as when the projects were being developed. But as far as do we have connections there? Yes, in that our services go out into the community. So there's individuals who reach out to Tri-City and complete the intake and are receiving services. They will have clinical staff, case managers, peer mentors, or peer specialists, like Sarah identified, go out to visit them and work with them as well.
Thank you so much. And then I think, if it's okay, since I don't see another one popping up, if I could ask a last question. I know there was, with any proposition, there's typically, there's the supporters and the opposition, and I know housing can be a really sticky subject for folks, and I'm just wondering if you could share any sort of like I don't know if the word is pushback, but any concerns or I don't know if you guys deal with that kind of direct, actually, I'll tie this in with Rachel's question because she's just asked a question too. And it might relate to pushback about housing. What's the status of the baseline housing project in Claremont?
So we do have a project working with RNLA and Genesis on baseline. It's going to be senior housing, so that is moving forward. There was a little bit of hiccups here and there just to make sure that we had all the funding, but everything's been secured, so we are moving forward with that. We're very excited to bring that project forward.
Awesome.
I'm sorry, what was it? There was a second part, I think, to your question.
Yeah, I guess just do you guys deal with that same sort of pushback that people sometimes have about housing in general, affordable housing, housing for folks who are dealing with various issues?
We have in the past, as we were working on the developments for that are already in existence. We didn't get any pushback for the baseline project because that was a by right project, so there really wasn't any. We didn't have to do community meetings for those. But we did have that with other projects that we had, and the location of developments changed over the years. This was before I joined the agency, but I do know that there was ideas of a different placement for the projects, and eventually they got where they ended up. So we do hear concerns about the community, but we do our best to try to identify that this is also being built for the community itself. We have another project online with Cesar Chavez down in Pomona on Holt, like near the indoor swap meet. And the bottom level of the project is a community medical center. And so this is open to anybody. And now the individuals who live in this neighborhood don't have to go very far to receive their medical treatment as well. They will be able to access it there. And there'll be a pocket park there for the community as well. So we try to do what we can to make the community feel inclusive as well to what we're building.
Yeah, thank you so much. All right. Well, I just want to say thank you so much, Sarah and Mary, and to Tri-City. We appreciate the work that you do so much. And so as my close, yes, Rachel would like to know, are there ways that our organization can support you guys? I don't know if you have any ideas about that.
I would actually, I know I already have everyone's email here, the two emails, and if you are open to it, and anybody else in the room as well, hopefully you had a chance to grab my email, but I can add you to a unofficial email list whenever we have public hearings, whenever we have community forums, which at some of these forums, it's just program updates and getting feedback about what everyone wants to know. At other community forums and stakeholder meetings, we're voting on unencumbered funds. What do you want to see as a community? So we just love to spread the breadth of our stakeholder reach as much as possible, because again, these are stakeholder dollars. And just like Mary was saying, that transparency, we want to be as transparent as possible. So yeah, staying connected through email. I'd be happy to add you to the distribution list, and likewise to anybody else in the room. And at any point, if you don't want to receive those emails anymore, let me know and I will remove you from the list. But yeah, staying connected, and likewise seeing how we can support you and continue our work that we did here today.
Oh, thank you so much. So again, I really, really appreciate your time giving us some of your Sunday afternoon. And thank you to those who attended the webinar. A recording will be posted on our YouTube channel soon. So thanks, everyone. I hope you all have a lovely Sunday afternoon.
Take care all. Thank you.